any pressure. For example, if you have a cast, for example, Berogen humerus, and you have a cast, and the cast presses, mechanical press. The nerve, for example, radial nerve, leads to some structural changes in motor and coronary system. Maybe there's some problem. Pressures or mechanical pressures up to 30 millimeters of mercury blocks venous flow. More than up to 60 blocks axonal transfer. Axonal transfer means transfer by axon. And more than 60 up to 120 millimeters mercury blocks intraneural blood flow. If it blocks the intraneural blood flow, has some problem. Sometimes if it's chronic pressure, leads to demyelination. Demyelination means no myelin, means disruption of myelin. Okay? Maybe open, maybe extensive. DLP means no. Okay? So mechanical pressure is one of the pathophysiology of nerve injury. The problem is sometimes some cases will come to the clinic with nerve injury. With nerve injury. Okay? Maybe stretch, maybe mechanical pressure, maybe ischemic makes problem. Golden nerve makes some peripheral nerve injury. Okay? So demyelination, sometimes there are some disease. It disrupts the myelins and damage the myelin. And sometimes there is the demyelination and then remyelination. The body has a process for remyelination. If there is a demyelination, so the body has a process for remyelination. So we have demyelination, we have remyelination. Sometimes the demyelination is very extensive, very profound disease. And sometimes, following demyelination, you have axonal degeneration. What do you think by axonal degeneration? What happens? Where are the other students? I speak, but there are no students behind them. That's a silent.
If you want, I go.
Really?
I can't. Every 50 minutes, I can change my name.
What do you think? If it's axonal degeneration, what happens? What do you think? If it's axonal degeneration. When I said it is axonal degeneration.
The cell won't be able to fire neurotransmitters and
don't able to fire.
Yeah.
Yes.
Will not be able.
And what happens in the patient?
Awakening or disability.
Which end muscle? Okay. No axon. Which end muscle? Okay. Axonal. So axonal unit. Following demyelination, you have axonal degeneration. Okay. And we have one process as Wallerian degeneration. This is very important. Wallerian degeneration. I will show you. Secondly, axonal degeneration. This type of site of injury you have Wallerian. Wallerian degeneration means degeneration of the rest of the axons up to the end. Degeneration means axonal. So Wallerian degeneration is important. I put in red one. Okay. So axonal degeneration also so to the distal of the side you have Wallerian degeneration. To the upper sometimes maybe you have degeneration. Sometimes to nerve cell, but sometimes to the first ganglion node. Okay. You have this. And this is due to edema. You follow the peripheral nerve, you have edema. And blood axonal flow. Axonal, axonal, transverse. Okay? So sometimes we have axonal injury up to here. Sometimes we have demyelination. Sometimes followed with demyelination we have axonal degeneration.
Yeah.
Axonal degeneration, I mean, is after the demyelination. Sometimes maybe we have axonal. Axonal we have weakness. Weakness. For example, as you see, sometimes we must have some weakness. And this is due to axonal degeneration. Okay? So it's very important. So Valerian degeneration, axonal. So demyelination, axonal degeneration. We have. Okay? And Valerian degeneration, axonal degeneration. And after that, there is a neuroplasticity also. We have neuroplasticity in upper, in CNS. Neuroplasticity in CNS.
Narinjia. Bola.
Yes. Neuroplasticity. Most of the time is in the upper motor neuron region. Upper motor neuron region. In CNS. If there is any problem in CNS, sometimes some of the other neurons can compensate instead of the dead neurons. It's neuroplasticity. Okay? Neuroplasticity. And in the peripheral energy, in peripheral also, sometimes, this is in CNS, but sometimes in peripheral, also you have some neuroplasticity. After axon degeneration, you have some repair, and this repair is sometimes by the system itself repairs. It's neuroplasticity. Okay? And it's very important when the patient comes through. So we have neuroplasticity in CNS, also in peripheral nervous system, we have neuroplasticity. Okay? So we have Valerian degeneration. So we have nerve. So we have nerve degeneration. What does that mean? This means that after axonal degeneration, we have nerve degeneration. This is neuroplasticity. Neuroplasticity. So it's not only for the upper motor neuron, only in CNS. If there is any problem in CNS, yes, you have neuroplasticity. Also in the periphery, it's important. You have neuroplasticity. Okay, so this means that nerve regeneration. Look at the distal portion of surviving axon begins to swell and sprouts. Means makes some sprouts. Between 4 up to 8 weeks sprouts. And then regrowth rates. 0.5 millimeters in 1 day, or 1 inch means 2.5 centimeters in 1 month. This is very important. The patient asks you, okay, I have a peripheral nerve injury. What do you think, as a physiotherapist, when is there any recovery for me? You cannot answer the question of the patient. If you consider this, maybe you guess, estimate. How can? You must measure the site of injury to the end of that muscle. For example, the site of injury is here, for example, and the last muscle is here, for example. You can measure from here to here and to say to the subject, this is about 30, for example, centimeters. Okay. And you know that every month 1 inch regrows. You must guess how many months does it take to regenerate. Now you can calculate. If the distance is 20 centimeters, and each month 2.5 centimeters regenerate, how long does it take to regenerate? You can repeat your picture. 20 centimeters, you can repeat your calculator. You can measure. Is it possible to give me the answer? 20 centimeters. 20 centimeters. Each month, 2.5 centimeters regenerate. How long does it take to regenerate? 8?
20 centimeters is 8 inches.
Yes. Very nice. 8 months. Yes. For 20, for example, this is guess, estimation. 20 centimeters is distance and is equal to 8 months. Because each month 2 centimeters multiplied by A is we can tell the subject it takes 8 months to regenerate. This is estimation. Okay, 8 months. If you tell to the subject, okay, next week you will be okay. Next week the patient comes, okay, you tell me. You told me next week I will be okay. Why not? Because you know that. You must mention. For example, this is the problem. For example, the last muscle is here, this one, multiplier, okay, centimeter, and divided by 2, 8 months. Maybe 8 months, maybe 9 months, maybe 10 months, maybe 7 months. Okay, but it's around 8 months. This is very important because the subject asks you, how long does it take to recover? If you tell them, okay, 2 weeks later on you will be okay, the patient comes to you. You told me 2 weeks ago, but it's not. No. I must measure. I must calculate. Sometimes I will tell to the subject, okay, what is this? Okay, it's 20. Please, to the subject, please divide it to 2.5. What's the number? 8? 8 months. The subject calculates better. 8 months. So, sometimes rigorous rate is 0.5 millimeters in 1 day or 1 inch in each month, and as one diameter unmillimeter the first remuneration proximal, and we have remuneration from proximal to distal, mature at 1 year sometimes. Slow conduction, and you have the slow conduction velocity. NCV is reduced. NCV, nerve conduction velocity, is reduced. In peripheral nerve, in JV. Okay? So, this is very important actually. And nerve reinnervation, if you have the endoneurial tube, reinnervation occurs to endoneurial tube. What is the endoneurium? Is the covering of each axon is by endoneurium. Distal target site, recovery plateau sometime between 18 to 24 months. Does it take it if, for example, if the injury is here, if the injury is in the plexus, you measure from here, it's 60 centimeters. Divided 60 centimeters. 60 centimeters. If the problem is here, in the plexus, and you measure to the end of the muscle is about 60 centimeters. Divided 60 to 2.5, maybe
24.
24 hours, 24 months,
2 years.
2 years. 2 years does it take to recover? But during this time, you made some physiotherapy techniques. During this time, you don't leave the patient. Please go home. If you leave the patient after 2 years, comes with a lot of weakness. But during this time, the doctor said the patient in the physiotherapy, and you give some electrical stimulation. Electrical stimulation. Maybe electrical stimulation. Stimulation plus exercise. Plus exercise. Plus aspirin. Do you know aspirin? Aspirin is a cast. Sometimes a cast, such as a cast. Aspirin. Aspirin is very important. It's orthosis. Orthosis. As you see, sometimes there is some orthosis for the nerve pulse. Nerve injury. For example, if the radial is, you have the radial nerve pulse, you have a spider spirit. And you see that? See? Spider spirit. From viscera, means to here, spider spirit. And then, every time you give some exercise as passive exercise and electrical stimulation. They believe that electrical stimulation makes the weakened muscle prevent from the weakened muscle. But at the end you have some weakness. If it takes 2 years, they go 2 years. Okay, 2 years. So. If it's physical separation of a neural tube, leads to poor prognosis. Because it's misdirection of nerve splitting, and it's not very common in compression, but you have muscle atrophy. If you have muscle atrophy, it means that you have disruption, muscle weakness, and muscle atrophy. If it's atrophied, you must prevent from atrophy. So with orthosis, with electrical stimulation, but you have a little atrophy. It depends on the surgeon. Sometimes surgeon may make some surgery for the nerve pulse. So muscle atrophy in this case is neurogenic atrophy. This neurogenic. Neurogenic means disruption of action. If you have axonal degeneration, you have neurogenic atrophy is very important. So when the patient comes to your clinic, please look at the atrophy. Is there any atrophy also? You see, for example, somebody you see there is an atrophy in FDR. Any atrophy. Search at home for atrophy. For atrophy images. Search for atrophy. There is an atrophy. This means that axonal degeneration happens. Axonal degeneration. So you have neurogenic. Sometimes the patient is immobilized. In the hospital, immobilization has a long immobilization. There is weakness, but it's not neurogenic. It's due to immobilization. And that's atrophy is disuse atrophy. We have also disuse atrophy. Not in this case, in upper motor neuron lesion. Disuse atrophy. So, disuse atrophy is in the central nervous system. patient is immobilized for a long time, so there is atrophy. But it's disuse. But this is no, this is axonal degeneration. This atrophy is due to axonal degeneration. Okay? So this atrophy is different from this atrophy. It's another thing. It's axonal degeneration. In this case, you have no axonal degeneration. In that case, you have axonal degeneration. Axon is very important for muscle. Okay? Any question? What is this? Oh, very nice. This is the atrophy of thenar muscles. Very nice. Look at it. This is the atrophy. Compare the healthy one with it. This is the okay. This is normal. In the clinic, can I show you that?
Yeah.
This is atrophy. See? This is healthy one. This is atrophy. See? No tenor. Look at it because it's very important. Okay? This is atrophy. Thank you very much for this. It's very nice. Okay? This is atrophy. Look at atrophy. Atrophy is very important. Okay? This is normal.
Ești gata pe ea vor putea mai zen.
That's do you know?
Ești gata pe ea vor putea mai zen.
Normal, isn't it? You chat? Yeah. Which one is abnormal? Yes? Yes, it's abnormal. It's very important. Atrophy?
Ești gata pe ea
You
vor
don't forget.
putea mai zen.
What do you think? Which one is abnormal? What do you think?
Zeynep şöyle bak.
No, this is abnormal. Really, please look at it carefully. Yeah, there is no tenor. No tenor. I'm not a policy benefits. Opponent's policies. Opponent's policies. Flexor policy benefits is a group of tenor muscle.
His hands for someone's work a lot.
Which one is abnormal? Look at. Yes? Yes. No tenor. No tenor. Thank you very much. This is due to axonal degeneration. Axonal. But sometimes we have this atrophy in upper motor neuron. CNS. Muscle atrophy is very, very important. Muscle atrophy in the clinic. Pay attention to the clinic. When you are in the clinic and the patient comes to you and says, what is this? This is atrophy. The patient asks you, what is this? This is atrophy. Yes. It's atrophy. So muscle atrophy is very important. Sometimes 1 to 1.5, yes, means 1.5. Okay? It's very important. And you see, sometimes there is endothelial fluid, and sometimes there is, after repair, there is some sprouting for regeneration. Okay? It's important. And categories of nerve injury sometimes is minimal. If it's minimal, rapidly reversible conduction blood, but the slowing of nerve conduction, sensitive, is reversible, rapidly, such as the neuroparex. Neuroparex means pressure. Intermediate means focal demyelination. Sometimes you have focal demyelination. It's intermediate, axonal. And if you have axonal levels, we have oral conduction blood. We have the same conduction blood. And severe, we have axonal damage with Wallerian disease. That's image related to axonal damage with Wallerian degeneration. Don't forget that. All the time, remember that image. Search at home for art. You will find a few examples. So the category is minimal, reversible, such as neuroparesis, pressure, intermediate is between, and severe is very, very. That's related to severe. That's atrophy. Related to severe problem. Okay? And there is a man, a Seddon, and we have classification of Seddon classification. There is a man who classified the nerve injury, okay? The nerve injury, classified. Seddon's classification. Based on amount of nerve injury. We have neuropraxia, mild conduction therapy. What does that mean? Conduction therapy. Pressure, most of the time. If the pressure is removed, so it will go. Maybe 1 week, 2 weeks, it will go. The most important example is Bell's palsy. Do you know Bell's palsy? Yes, we know. There is Bell's palsy. Bell's palsy. This is a kind of neuropathy. Some pressure on the cranial nerve, facial cranial nerve. Facial, cranial nerve, 7 nerve. The patient wake up and say, oh, there is some paralysis in one side of my face. This patient gets lost. We look at the mirror and say, and see that there is some paralysis here. I cannot elevate my eyebrows, I cannot close my eyes, I cannot look, such as this, and this is related to Bell's is facial cranial nerve involvement. It's such as the neuroparesis. After 1 month, it will be okay. And the patient, the doctor, neurologist sends the patient to physiotherapy for Bell's palsy. Sometimes in the clinic of physio, you have Bell's palsy. They are the best case come to physiotherapy because after 1 month or 2 months, they will be okay. And they said, this physiotherapist makes me very well. Okay? Okay? Is the chance of the physiotherapy. When you come to a clinic after 2 months, all the person, this physiotherapist makes me recover. Yes. I had a lot of cases, sometimes they say, oh, sometimes maybe by passing the time also it's better. But physiotherapy helps you. Okay? But they thought that no, this physiotherapy makes me better. Okay? So, Bell's palsy is sometimes that in your clinic you have Bell's palsy. It's a kind of neuroparesis or neuroparesis. And they said something like the neuroparesis. Another type, Seddon classic. Seddon is the name of it. Axonomesis. Axonal disruption, intact and movement. If you have axonal stenosis, sometimes you have some atrophy. But there is a tube for repair. It's okay. Okay? So you have axon disruption, intact and movement. But sometimes you have neurotoxicity. Neurotoxicity is very severe. In this case, axon disruption with loss of endoneurium and sometimes perineurium and epineurium as well. In this case, neurotoxicity or severance. Sometimes something that there are severance. Severance. Okay? This is very, very severe. Epineurium, perineurium, endoneurium, all of the covering sheets are cut. In this case, only microsurgery helps the patient. Must microsurgery and then sensitive physiology. Under the microscope, electron microscope, under the microscope, there is a microsurgery to repair each possibility. Very sometimes 4 or 5 hours takes for the surgeon to do this. It's very important. So this is very important. So neuroparalysis is okay. It will go okay, no problem. Sometimes one example of neuroparalysis. Sometimes you have one example you have broken area in femur or the tibia, and so you have a cast. The cast presses on the fibula. You know that this is the fibular head, and the fibular head and the fibular nerve or dipronar nerve rotates the fibular neck. And so you see the patient says, okay, I have some drop. This is due to the mechanical pressure of the cast. If you remove the cast maybe after 4 or 5 weeks, or maybe you have the doctor has another suitable cast on this patient. So neuroparalysis is nice. I mean between 4 and 8 weeks it will recover, but this one is very severe. Okay? Okay. So neuroparalysis is conduction block. No axonal degeneration. Large mediated fibers more susceptible to compression. Ischemic, motor, nerve conduction is normal distal. Because there is a pressure in low distal, normal conduction velocity. But across the injury side is altered, changes. And normal conduction details in days or weeks, 4 or 8 weeks, due to remediation. Sometimes maybe in neuroparalysis you have 4 months remediation at the start of the pressure, and then it will be repaired during the 8 weeks. Okay? So this neuroparalysis is the best example of deferred injury with good prognosis. Good prognosis. Good prognosis. If the patient has a neuroparalysis, okay, you will be recovered. After 2 months, you will be recovered. Okay? It's good prognosis. And what in axon physics you have axon damage. Sometimes you have the preservation of endoneurium, epineurium, and perineurium. It's okay, but it takes time. Axon damage. Most of the time, compression, most of traction. If you have a traction, for example, an outstretched hand, sometimes maybe retracted. Okay? Sometimes some accident retracted. Okay? But if you have bodily agitation, you have axon. Motor velocity between 4 to 7 days, sharp decreasing. Energy fragmentation, okay? Sensory density lasts near 8 to 10 days, okay? And preservation of endoneurium allows for regeneration with reinnervation. Reinnervation means regeneration. Regenerate again. Recovery time depends on distance for reinnervation. How much is the distance? 20, 50, 30, divided by 2.5, so good. 8 months, 10 months, okay? So look at the Valerian degeneration. And neurogenesis is disruption. Disruption of sometimes perineurium, epineurium, endoneurium. Good prognosis. Good prognosis for neuroparalysis. Bad prognosis for neurogenesis. And action prognosis is in the middle between the good prognosis and neurogenesis. This neurogenesis needs microsurgery. But not if there is a problem now for the nerve, it's not okay go to the operation room. You must take some time. in order to remove the edema, inflammation, and then repairs. Sometimes between 2 weeks, but sometimes between after 4 weeks, they go for repair. End-to-end repair. This is, for example, this is the rupture. Is neurotoxins. And then the surgeon will start repairing there. But microscopy, okay? The facility makes it tube in order to, by neuroplasticity of the system, to regenerate. Okay, to regenerate. So you need this one by the side. Okay? So put prognosis. And you see this, the different, it is a electron micrograph of the epineurinum, perineurinum, endothelium, and fascicle. And also there is another classification by Sunderland. The 5 degrees in Sunderland, conduction block is acetone 1, is neuroparaxia, axonotmesis is acetone 2, equal, but number 3, 4, and 5 is equal to neurotoxicity. So we have Sunderland, maybe in the future slide I will show you. Sunderland have 5 degrees. Degree 1 is equal to number 1 acetone, neuroparaxia. Degree 2 is equal to axonotmesis, and degree 3, 4, and 5 is equal to neurotoxicity. Okay? I will show you the next slide for polyneuropathy, and then you have a group discussion. Okay? So, any question here? No? No question? I will ask a lot of questions of you, but if you have any question, this is so the peripheral nerve injury. You have some cases in your clinic. Peripheral nerve injury. Maybe it's neuroparaxia, axonotmesis, neurotoxicity. Okay? In the clinic, the second classification is important than Sunderland, most of the time. So, okay, what is your case? My case is neuroparaxia. What is your case? My case is axonotmesis. What is your case? My case is neuroparaxia. What is this your case? My case is normal. Okay? Okay? It's very important. Okay. Talk about this. Okay. This is the Sunderland. This is the Sunderland. This is neuroparaxia. According to Sedon, is the first one is for number 1 Sedon. The number 1 Sunderland. Number 2 axonotmesis is equal to Sedon. Axonotmesis number 3, 4, and 5 is neurotoxicity. As I told you, okay, is neurotoxicity. You see, in this case. What can we do for this case? End-to-end repair. It's very important. Maybe in this case, repair by itself. But and in this case, if the pressure is probably the pressure is removed, maybe there is a recovery. Okay? So it is so. But that's peripheral traumatic injury. nerve injury, axonotomesis, neurotomesis, for example, with a knife, with a sharp object, with shooting, with falling. Any trauma, axonotomesis, neurotomesis. But sometimes you have some disease and the peripheral nerves are involved. This is not traumatic. We have some disease affects on the peripheral nerves. Affects on the peripheral nervous system. That's disease. Okay? Sometimes you have a mononeuropathy. Mononeuropathy means only affects on one nerve. Maybe there is some in this case, in mononeuropathy, sometimes maybe also there is trauma, mononeuropathy, such as the peripheral nerve. Maybe it's compression. I mean that the mononeuropathy is sometimes by trauma, sometimes by traction, sometimes by ischemia and inflammation. It's the same as is affected. When one nerve is affected on one nerve is a mononeuropathy. It's such as the peripheral nerve injury. Trauma, pressure, compression, ischemia. Okay. This is like the other peripheral nerves. But sometimes you have mononeuritis multiplex. Multiple nerves involved. For example, median in this ulnar in this, common in this, tibial in this, different, as I told you, axillary, musculocutaneous, radial, ulnar, median in the vestibular, sciatic, tibial, common pulmonary nerve, sural in the labrum is important. Multiple nerves involved, asymmetrically. Symmetrical means this median and this median. Asymmetrical means median in this case, ulnar in this case, in this limb. Tibial in this limb, carpal in the other limb. Femoral in this limb, sciatic in the other limb. This means that mononeuritis multiplex. Okay, multiple nerve involved asymmetrical. For example, DM, diabetic mellitus, diabetes. Some patients have diabetes, and we have polyneuropathy due to diabetes. Okay? We have neuropathy due to diabetes. The patient is a diabetic patient has neuropathy. The patient says, oh, I have a tingling, I have some problems, I have burning sensation, I have no sensation, I have loss of sensation. Some patient with diabetes. That's neuropathy due to diabetes. No trauma, no traction, no compression, no pressure, no ischemia, but has some problems. This is mononeuritis, diabetic mellitus. Abbreviation is very important. DM is, and also we have another DM, I will tell you. And sometimes you have polyneuropathy. In this case, polyneuropathy is symmetrical. Concurrent and symmetrical. Multiple nerves involved, but symmetrical. Median, ulnar, radial, tibial, dipulnar. This is symmetrical. But if median, ulnar, tibial, dipulnar is asymmetrical. In Arabic, we have qarine. Qarine means symmetric, yeah? Qarine means symmetric. Qarine or nazdik.
متقارن منظورتونه
آره دیگه مدياني ومدياني هنا.
في متقارن يعني نفس الشيء بأي جهة.
In this median, in this and also median, it's symmetrical. It's clean. I don't know. Okay. Sometimes diabetic mellitus, diabetes, maybe some polyneuropathy. Sometimes acute inflammatory demyelinating polyneuropathy. IDP, acute inflammatory demyelinating polyneuropathy. Sometimes chronic inflammatory demyelinating polyneuropathy. It means that the polyneuropathy is due to demyelination, is chronic and inflammatory. That one is acute. We have acute. Sometimes you are in the hospital, you see some patients, all of the nerves are involved and they are in an acute stage. And for example, 8 nerves are involved without any operation, without any trauma, without any knife, without any shooting. It's due to some disease. And you see, oh, the patient is lying in the hospital. What happens? Please do this. I cannot. Please extend. Please relax. Please extend. No. Why? The patient says, I don't know. But we know that this is due to polio. Do you have any diabetes? Yes, I have diabetes. Do you have any problem? Yes. And then you find the reason. This is polyneuropathy. Polyneuropathy is very important. You have a lot of cases in the hospital, especially in the hospital. Okay? Sometimes the polyneuropathy in classification, you have also demyelination, sometimes you have oxalopathy. Listen to me, no trauma. No trauma, but you have oxalopathy. Is a disease. Something called polyneuropathy. And you see, stocking and glove. This is such as a stocking and this is glove. Loss of sensation. The patient says, I don't feel. Do you feel? No. Do you feel? No. Do you feel here? No. Sensory ambulance is a kind of polyneuropathy. This is very important. It's a nice thing. Nice stuff. Stocking and glove. Type sensation problem. And also, in this case, diminished deep tender reflex. Deep tender. If I, oh, this is diminished. No answer. And sometimes in this patient has autonomic function in involved areas. Autonomy. They have dysautonomia. Sometimes the subject has a lot of brachical, tachycardia, the heart. Sweating, blood pressure. All the time look at the face of your patient. All the time. You see, if you look at it, you see, there is a lot of sweating in the face, heart rate increasing, blood pressure changes, and in this time you must stop the physiotherapy because there is dysautonomia. Look at the face of the subject. So, there are a lot of, you see, sometimes in some severe, you have a lot of sweating. Maybe the patient died. Please stop the physiotherapy. And please inform the supervisor of the ward and the ICU doctors come here and solve the problem. What's the problem by this? That's dysautonomia. Has a polyneuropathy in that just a lot of bradycardia or bradycardia or low blood pressure, high blood pressure. This is related to autonomic nervous system. ALS. Related to autonomic nervous system. Sweating, high blood pressure, bradycardia, increasing heart rate. This is an emergency. You cannot stand and look at. Go to the supervisor of the blood. Please come. Please inform the specialist doctor in the ICU. And in Iran, maybe I was not in the hospital of Iran, but in Iran there is a code, and they page, and at the same time maybe 8 doctors come to this room.
Yeah, blue code.
Yes.
Yeah, we have.
Code. We
Yeah,
have.
code, yeah.
Very important for resuscitate the patient. Code. There is a code.
Emergency patient.
Yes, emergency. There is a problem. One patient may be done. Please inform me if there is any problem. I will go to the supervisor. Please come. The supervisor nursing come. Okay, and then makes the code. And then the patient in the hospital, along the hospital, and there are some special doctors must come. They will come.
Yeah.
What's the problem? And then if they need any help, they help the patient. It's rare. It's not very common, but it's rare.
Yeah.
You must know. Autonomic function is very important. So in this case, some toxins, which some if you some poisons or toxins material or alcohol, some alcoholics make some alcoholic neuropathy. The patient is drinking alcohol, they have alcohol polyneuropathy sometimes. And in the Holy Quran we have إنما الخمر والميسر رجس من عمل الشيطان. There is why. And a lot of people who have drinks, they have, if we examine them, please do this. You see, the patient they have some reaction. Is this reaction? And when we measure the conduction velocity of something, we say, this is alcoholic neuropathy. Alcohol. Okay? Alcoholism and chemotherapy. Sometimes some patient is malignant, they have chemotherapy. Due to that cause also we have polyneuropathy. So in malignancy means in Arabic, malignancy, we have to count benign. And malignant is very bad. Malignant cancer, for example, benign cancer is not too bad, but this is very bad. Cancer. Do you look at the tumor?
Yes.
Malignant.
Salman Hamid.
Yes.
Hamid. Ben.
Benign. And what of the malignant? Khabis.
Yes.
Yes. Sometimes in malignancy, they have some chemotherapy. Due to chemotherapy has polyneuropathy. It's side effect of some chemotherapy. We have polyneuropathy. But what can we do? We must do the chemotherapy. But sometimes we have to. So look at the polyneuropathy. Okay? And this is a mirror. Sometimes you have myelinopathy. For example, acute inflammatory demyelinating polyneuropathy means demyelination. Or chronic inflammatory demyelinating polyneuropathy. Look at it. This is a good and normal nerve and the neuromuscular junction, as we told previously, or the neuromuscular is myelin is okay, axonal. In this case, the antibody injures axonal membrane, and then you see the axon is defragmentation. Fragmentation. Okay? But the myelin is okay. In this case, the antibody affects the axon is okay, but the myelin. So we have axonopathy, we have demyelinopathy, okay? So we have myelopathy. Okay? Sometimes we have some problem in the motor neuron. This is the motor neuron. Sometimes there is some problem with the motor neuron. If this is the spinal cord that I had a lot this for you. If this is the anterior horn cell and these motor neurons are destroyed, is motor neuron disease. And the best example is ALS, amyotrophic lateral sclerosis. Motor neuron disease. Motor neuron disease. Sometimes when you go to ICU, you see some patient with motor neuron disease. There is a lot of atrophy, intrinsic muscle, FDI muscle, tendon, hypotendon, atrophy, as you show, atrophy, such as. And in some cases, you have respiratory problems because the intercostal muscle also has problems. The patient cannot breathe. It's very difficult. It's under the mechanical ventilation. Some minutes apparatus makes respiration. In this case, it's motor neuron disease. Motor. The respiration is very difficult in motor. So the motor neuron disease inside the and these motor neurons also the respiratory problems. In motor and health system also has some neuropathy. Okay. And for diagnosis, we must do nerve conduction studies. Next session I will explain nerve conduction studies, NCS, in order to measure the NCD. Most of them from the cerebral nerve and a biopsy. In neuropathy, sometimes we must make a biopsy. Biopsy means to take a piece of the nerve. Do you know what is the cerebral nerve? The cerebral nerve is responsible for what? Yes, here. In the foot. Here. Lateral border of the foot is innervated by sensory cerebral nerve. Okay? So, biopsy. And the operation, the neurologist makes a biopsy and sends the biopsy to the histology to see under the microscope what happens for the nerve. Sometimes you have biopsy, especially for mononeuritis conditions. Alright, okay? Biopsy. So, nerve conduction study, I will tell you in the next session for you. And there is a case at GBS, as I told you all the time for Guillain-Barré syndrome. GBS, Guillain-Barré syndrome. Okay? So, it's an acute inflammatory demyelinating polyneuropathy characterized by progressive muscle weakness and heart rate. What does that mean, RFRA syndrome? Is no. Why? Because this is for polyneuropathy. If I do, for example, if I do the bicep tendon, no reference. In normal, you have this reference, but that one you have no reference. Okay, this is Guillain-Barré syndrome, and also affects on the respiratory muscle sometimes. Sometimes it doesn't affect on the respiratory, but and the prognosis is okay sometimes. After 4 weeks, it will come. But there is some residual, symptoms will remain. but all the time is the recovery is okay, but the patient has some weakness. Okay, so it's a demyelinating process. Sometimes GBS is demyelinating, demyelinating. Okay, demyelinating. Okay. For demyelination in upper motor neuron, we have multiple sclerosis. This is in lower motor neuron. In upper motor, we have multiple sclerosis. Sclerosis. MS is in lower upper motor neuron. Okay? But program is progressive. Muscle weakness or weakness. Okay? So this is GBS. Okay? Sometimes post-infectious. Sometimes you have some cold. You get a cold, and after cold you see in some patients the autoimmune system invades to the peripheral nerves and destroy the myelin sheath. And so you have a pulmonary problem. Sometimes after COVID-19, there are a lot of patients in the hospital. They have polyneuropathy, as Gillian. After vaccination for adults, when the passengers want to come to Karbala or to Hajj, and they have vaccination, after vaccination they have a Gillian. I see in the hospital, after vaccination, for Hajj or for Atal. Sometimes, previously for Atal also there was some vaccination in Iran. And for Hajj, there is vaccination. Maybe in 1 million. Oh, thanks. It's by chance. It's by chance. Following COVID-19 in the hospital, there was some virus. Okay? But the prognosis is okay. I know after 4 or 8 weeks, he or she will be okay. Okay? Post-infectious, polyneuropathy, ascending polyneuropathy viruses. First in the lower limbs, and then progress to the upper. Okay? So, an acute, rapidly progressing and potential fatal sometimes, if it affects on the respiratory system. Or affects the peripheral nervous system. GBS is a peripheral nervous system disorder. Post-infections, post-COVID-19, post-any cold, post maybe it's 1 in 1 million after vaccination. We have, in Arabic, we have aham fel aham. Due to vaccination, it doesn't mean no vaccination. No vaccination is okay because we want to go to Hajj, for example. We want to have vaccination. But this is by chance, 1 in 1 million. What can we do? Maybe it's my chance, maybe it's your chance, maybe I do it. Who knows? Okay? But aham, we have aham, fel aham. مهم. And this is the peripheral nervous system, somatic is called and in this case, this is the normal case, myelin, axon, myelin shear shrunk, and this is damage of the myelin in Guillain-Barré. Sometimes they prevent the nerve in Guillain-Barré. Damage to myelin sheath, demyelination, and loss of myelin, edema, and inflammation of the affected nerve cause a loss of neurotransmission to the periphery. Means the neurotransmission to the periphery is involved. Neurotransmission, what does that mean? Means transmit the neural impulse. Along the difference is damaged. 85 patient recovery with supportive care. They have, for example, their medication, they have physiotherapy, they have stability, they will be okay. If they have some problems in their, for example, ventilation, in the ICU, okay, they must be on the mechanical ventilation, and maybe they will be recovered, okay? And clinical presentation is the initial symptoms are the path. Okay, in the polyneuropathy of Guillain-Barré, you have paresthesia. Paresthesia in the toes, in the fingers, followed by lower extremity weakness that may ascend over hours or to days inward. Okay, from the legs, it starts with the legs and then with the arms. And also maybe you have some cranial nerves. Some cranial nerves. For example, you have some dysphagia. What is the dysphagia? Dysphagia is trouble in swallowing. They cannot swallow solid. Sometimes you have dysarthria. Dysarthria is problem in articulation. You cannot speak very well. Sometimes you have dysphagia, dysarthria, or dysarticulation. Cranial nerves. Okay? Dysphagia, dysarthria. Oh, diplopia. Sergeant, you have diplopia. Double vision. Double vision is not okay. You see, for example, I see Mr. Hussein too.
Very difficult.
Yes.
He's one I can't
For example,
control.
I see this tablet, two tablets. All the time you want to be in a double vision, diplopia. Double vision. And it is repeating the muscles of respiration, respiratory problems. So, cranial nerve, there's sometimes you have facial ones, as base ones. Sometimes you have diplopia, double vision. Sometimes you have dysarthria, dysarticulation. You cannot speak very well. Dysphagia, you cannot swallow. Cannot swallow. Bad. Bad. It's very difficult. Sometimes you These are due to involvement of cranial nerves. Okay? So these are the So cranial nerves. For example, first one is by facial. If you are a good physiotherapist in the clinic or in the hospital, you can, and you are a good member of that hospital. All the time, all the doctors, okay. For example, the physiotherapist is very okay. Yes, it relates to you, okay? So, 50% present in symmetric, distant, so paresthesia is very important. Means tingling, means loss of sensation, means burning pain. Before clinically evident in weakness, sometimes you have weakness, paresthesia, numbness, tingling, loss of sensation, followed by paralysis. So, paresthesia, paralysis. Paralysis by weakness. Paresthesia with loss of sensation, tingling, burning. Okay? So, in pulmonary, sometimes you have weakness. In this case, maybe you have some paresthesia. Paresthesia is very important. The patient said, you must ask the patient, do you feel any sensation? Yes, I have burning sensation. I don't sense, yes. And sometimes dysautonomia, as I told you, dysautonomia, bradycardia, a lot of sweating, respiration, changing of the rate of the respiratory, E-levels, tachycardia, bradycardia, sometimes urinary retention, incontinence, urinary incontinence, these are the autoimmune. You must pay attention. And all the time, if you have a good study, okay, if you are a good physiotherapist and have a lot of study, you can discuss with your doctors about the problems of your patient. Yes. Most of the time, I discuss with the doctor. Okay, what's your opinion about this problem? And we discuss with the doctors. It needs more study. Study more. If you study more, you can discuss with your doctors. Okay? This is so. If you don't study, you cannot discuss. Really? If you study, you can discuss. Okay? And weakness, Allah weakness, you must be attentive. No, there is a weakness. Right. In your fight, there is a weakness. There is a parasite. Pain in the form of muscle cramps, muscle pain, hyperesthesia, means more sensation, worse at night. And also, 2 or 3 slides, I will finish and then do discussion, maybe if there is.
No, Subhanallah.
27.
Okay, after this you can go for rest and then come back for this and then I will continue for the lesson. So, sometimes we have my work. This class, peripheral nerve injury, Guillain-Barré syndrome, mononeuritis, polyneuropathy, multiplex, okay? Guillain-Barré, and the different, that's the. But we have sometimes we have to find out. What does that mean? This problem is inside the muscle. The neuron is okay. The peripheral nerve is okay. Only the problem is in the muscle. 2 kinds of, this is better to read. One is dermatomyositis. When we say DM, sometimes DM means DM. Sometimes DM means diabetes, mellitus. Is diabetic. Sometimes DM means dermatomyositis.
So how we can define no we start
There are 2 abbreviations, DM.
yes.
If you write DM, please write at the end what is your meaning
No,
of DM.
the question of the slide, how we know.
Oh, in the question, I put the whole.
Oh.
Dermatomyositis or diabetic?
Oh, no.
No. So, we have dermatomyositis here. We have polymyositis here. Polymyositis, 2 cases. Okay? So, okay. In DM, dermatomyositis, what does that mean? Means a skin. Means involvement of skin and muscle. Myositis means muscles. Means inflammation of the myelin, of the muscle. Dermatom means inflammation of the skin. Dermatomyositis means is a kind of myopathy affects on the skin and muscle. The characteristics, some facial rash. There are, if you go to a neurology department and sometimes to rheumatology, you see the dermatomyositis. There is some rash on the face. I will show you. According around the eyes. Yes. The nerve, it doesn't matter. Head, throat, rush. Rush around the eyes. I will show you. Muscle pain is affecting muscle. Proximal weakness. Most of the time, the myopathies affect on the proximal. Neuropathy affects on the distal, most of the time. But, yeah. So, in neuropathy, most of the time, in neuropathy, for example, peripheral neuropathy, we have distal muscle involved, distal muscles involved. In myopathy, most of the time, proximal muscles. Proximal muscles are involved. One difference between the peripheral neuropathy and myopathy is that in myopathy, most of them proximal muscles are involved. Ring, shoulder, most of the time. But in neuropathy, most of them, the distal muscles are involved. Okay? We can distinguish. We have proximal weakness, and this proximal leading to joint contraction means shortening of the muscle, and the age spectrum is 5 to 50, sometimes middle and sometimes in old. It is in old myopathy or dermatopathy is due to malignancy, khabis, malignancy, cancer, khabis. And physiotherapy minimize the contraction. In this case, minimize the contraction. Sometimes for dermatomyositis in rheumatic center, they send for physiotherapy. No, not they send. You must go to the ward for physiotherapy to do some exercise for preventing of contractions. But it's better to know the disease. Okay? Look at here. The rush around the eyelids, rush. And the rush here, around the, so this is the dermatoma and weakness. You see? Dermatosis must be under the corticosteroid therapy. Sometimes maybe for the all the time, up to the end of the life. Corticosteroid therapy. For example, prednisone. The rheumatologist give prednisolone for reducing the inflammation. This is very nice. The eyes and hands rush. This is dermat. Means dermat. And also, if you have weakness, especially in proximal, it's dermatomyositis. Okay? And look at here. Rush here is Gottron's side. Sometimes it's Gottron's side, but this is. And sometimes mechanics hands. Okay? There are a lot of contractions sometimes. And heliotrope, as you see, around the eyes. Heliotrope rush. And another rush on the sternum. Okay? We have another type. Another type of myopathy as dermatomyositis or polymyositis. Polymyositis means involvement of a lot of muscles. And sometimes in rheumatology, when you enter to the rheumatologic department, you see there is some patient, they lie on the bed and say, what is this case? Oh, this is polymyositis. Means a lot of muscles, especially proximal muscles. As you see here, proximal muscles, shoulder girdle, and limb girdle, pelvic girdle, and also some biceps muscles are involved. So shoulder, hips, thighs, back, pharynx, and sometimes pharynx means the pharynx for swallowing, maybe there is some problem, and neck, the rest of the regions are involved. This is the inflammatory myopathies with progression, symmetry, proximal muscle weakness. Please know that myopathy has proximal muscle weakness. Neuropathy has distal, most of the time, but sometimes maybe also in polymyopathy you have distal. Okay? So, the antibody affects the myofibers, okay? And makes some muscle degeneration. What about the neural function? Neuron skeletal muscles, and this is, you see, this is the inflammatory cells attached to the muscle fibers and degenerate the muscle fibers. So it's polymyxate parasitic, subacute, proximal, proximal weakness. So remember, in neurogenic disorder you have distal weakness. In myopathic conditions you have proximal weakness. They cannot come, they cannot eat. ADL activities daily of living are involved. They cannot eat, they have some problem with toilet, a lot of problems. Most of them for okay? And this is now have a rest, and then after the rest coming for a discussion, and I will continue for the last one. Okay? Any question? Any question?
No.
Any question? Any question? Any?